All right, welcome everybody. We have a fantastic video today for Murmur MD. We are joined by Sam Horr, who is the head of cardiovascular research at Centennial Health in Nashville, Tennessee. Sam is a super high volume structural heart interventionalist who's seen tremendous growth in his WATCHMAN program. And what we're going to talk about today is WATCHMAN outreach, how to increase the volume of LAO procedures that you're doing in your practice. And we're really honored to have Sam. He's had some great growth in his program. He's got some great tips and tricks. Sam, welcome, buddy. How's it going?
Thank you for having me. Excited to be excited to join you and join Murmur. Thanks for having me.
Awesome, dude. Well, so I just want to start by kind of setting the stage. I think that a lot of structural heart interventionalists out there spend a lot of time and effort growing their TAVR and mitral program. But I do think LAAC is one of those procedures that kind of takes a back door to, or a seat in the back to the rest of the structural heart procedures we do. But I really think that you probably get the biggest ROI for any efforts you expend on outreach with LAC, because it's a therapy that's underutilized. We know that it only penetrates 5 to 10% of the eligible patients out there. And I think just a little bit of effort in trying to increase your volume and trying to increase your outreach can result in huge benefits in terms of volume growth for your program and for your market. And I do think of all the procedures we do, it's probably the most rewarding, both from a reimbursement perspective. You know, it takes about 10 minutes to do a straightforward WATCHMAN, and the RVU is about 14. And I do think it's very, satisfying when you see patients get off their blood thinner. And so, we wanted to do a conversation today about outreach for LAC and how to increase it. So, I've put together this little mnemonic, which I think are 5 simple steps that any implanter can use to increase their volume. But I think before you try to increase your volume, you really have to be able to scale. And so in order to increase your volume, you have to be able to accommodate the influx of patients that you're going to go after in your outreach efforts. Because if you double your referral volume for WATCHMAN procedures, but you can't accommodate those patients, and those patients are waiting, they're not only going to have events, but they're also probably going to cancel the procedure, because there's a phenomenon with WATCHMAN where that 30-day window from when you see the patient in clinic to when you actually do the procedure, we know there's a huge drop off. And there's some evidence behind this. So I think the first thing is to scale your program. And so basically look at how many LAC procedures you did last year and double it, and try to scale your procedure workflow to accommodate that. And so, Sam, I know this was a big part of your guys' outreach efforts. So can you talk a little bit about how you were able to scale your program to accommodate the influx of patients? And maybe start by talking about some of the growth you've seen. I'm going to put up your growth chart, and I think it's been incredibly impressive.
So thank you. Yeah, so you can look at our growth chart here. So back in 2017, 2018, our WATCHMAN numbers were right around 50 or under per year. And we exactly thought the same you did. We thought this was a huge growth opportunity. If you look at it over the past 5 years, it's the fastest growing structural procedure is the LAO. And so we saw that back in 2018, that it was a really opportunity we were missing. So the first step we did was really to put the infrastructure in place. We had no dedicated coordinator. Our coordinator was doing both TAVR, MitraClip, and WATCHMAN at the time. And to really scale, you need somebody who can handle the volume. So the first step was to hire a dedicated coordinator. Once we had that in place, we started thinking about, well, what are our inefficiencies? It's a very resource heavy procedure to get going. And so depending on how your procedure is, you may have anesthesia involved. As somebody who's doing imaging, you need a shared decision maker that's a non-implanter. And so we had to get all of those pieces in place in 2018. And when we did, you can sort of see what happened. We started with nothing more than infrastructure in 2018. That allowed us to take the next steps over the next 5 years to really grow the program.
Got it. And in terms of so you're doing 300 WATCHMAN a year, which I think is incredibly impressive. So how are you balancing that procedure workflow, Sam, in terms of how many cases are you doing a day? Are you doing 2 rooms? How are you managing your imager and your anesthesia? Can you talk about what the everyday kind of structural interventionalist needs to do to be able to accommodate growth like this?
So any procedure, you're going to have some sort of roadblock. And I think every hospital is different in how they assess the roadblocks and then how to overcome them. For us, it was the procedure dates, the number of procedures we could actually do on a day due to anesthesia and imaging. So we currently still use GA with TE guidance. I know some programs have overcome those by moving more towards ICE. We have not. We actually worked with our anesthesiologist that when we schedule a Watchman day. We do 6 to 8 procedures in a day. We get 2 rooms with 1 imager who goes back and forth, and 2 CRNAs. And so what we've said is we can do 6 to 8 before lunchtime. And so by doing that, we then free up our CRNAs to go help in other places. We also then free up our imager to go do the rest of the TEs for the hospital, things that need to get done in the EP department, et cetera. And so we have worked our efficiencies that way, in which we bulk procedures. So instead of doing 1 or 2 per day, we do 6 to 8 per day with 2 rooms.
I love it.
So we do that every week. And so we actually have 4 implanters that do this. And that's how we've basically been able to scale the procedure day.
Got it. And can you talk a little bit, Sam? So are your 4 implanters, are they all ICs? Are they a combination of IC and EP?
What is combination?
Okay. Yeah. And so is it 2 and 2? What's the balance?
It's 2 and 2. And we actually added a 5th implanter. Now that I think about it, we actually added a 5th implanter. So we have 3 ICs that do it and 2 EPs. 1 coordinator works for both, but actually now that we've scaled so quickly over the past years, we actually added a 2nd dedicated coordinator and a dedicated a nurse that helps the coordinator with arranging all the procedures and follow-up appointments.
Man, that's impressive. And so, I think it's super important to have buy-in from your EPs. So I think a lot of programs really need to embrace bringing in an EP into these procedures, because at the end of the day, I think they have the most of the AFib patients. Has that been your guys' experience? Do you feel like having the EPs as part of this program really helped grow it? And how do you guys coordinate with them in terms of referrals? Does it go to the individual doctor, or do the referrals just get split up among the program?
So we have our EP clinics, the non-EP implanters. So the EPs who are non-implanters were really the people that we also had to get buy-in from, because they're going to be referring to their EP partners that do it. And so we had to get buy-in from that whole EP group, which really has been helpful, honestly. We, as you'll talk about later, we do a lot of sort of market outreach with the EP physicians, because in the end of the day, that's where the patients are usually held, is by the EP physicians. Getting their buy-in initially, what we try to do is, what you can do is you can actually co-surgeon these. When we first started our program, if you double scrub an EP and interventionalist, you actually can double your billing, almost 2/3 and 2/3, similar to what it is in TAVR. Eventually, we got to where the efficiencies were so great, and Watchman became a regular procedure that took under 20 minutes for most cases. We actually found that double scrubbing was less efficient. But by doing that early up front and having them in the procedure with us to start the program really helped get their buy-in. And now we do it separately. But that initial early experience of including them was really, really essential.
No, I totally agree. Yeah, we have 3 implanters, 2 ICs, and 1 EP, and our EP is one of our best referrers. And he's convinced his other EPs to refer as well. And similar to you, we do 6 every Friday. And so we're on track to do 300 as well. And I think that, it's only going to grow. So we're thinking about adding a day. And so I think this whole scaling thing is super important to do up front, because if you see a double of your structural heart, LAAC referrals, and you can't accommodate those patients, you're going to get behind the 8 ball. So I think that's the first step, is scale your program. So when I go back to the mnemonic here, the S is scale your program. The C is close the eligible patients you see in clinic. And so, this should be 95% or more of patients who are eligible and meet indications for Watchman. And I do think doctors need to realize that at the end of the day, our job is to articulate to these patients the value of this therapy and to articulate the reasons and the risks and benefits. And I think this is one of those procedures that's so low risk. We're talking less than 0.5% chance of major complications, that when you compare that to the long-term risk of being on a DOAC for the rest of your life, I think you really need to refine your discussion with patients to make it as articulate as possible and to get the point across. And so we've got a great video on murmur. You can search on murmur how I close LAAC patients and see kind of the spiel that I use. But essentially what I say is that if you think about it, 95% of the stroke causing blood clots come from the left atrial appendage. Somewhat arbitrarily, we use blood thinners in these patients to thin out the blood in your whole body, just to address this small part of your anatomy. And so we're really trading one problem for another. We're reducing your risk of stroke, but we're significantly increasing your long-term risk of bleeding. And Watchman is a really elegant solution for patients like yourself who are either at high risk for bleeding or have bled. And this allows you to get off your blood thinner for the rest of your life and mitigate those risks of bleeding, but still have all the benefits of stroke reduction. So Sam, do you kind of have a set spiel when you see patients in your structural heart clinic for how you talk about this? And can you talk about kind of your talking points for that?
Definitely. So very similar to you, I think nobody wants to undergo a procedure, right? So no patient comes in there saying, I absolutely want a procedure. And what you have to explain to them is that if the alternative is to not be in a blood thinner because of their bleeding risks, that a procedure, especially as Watchman, has become so safe. And as you mentioned, less than 0.5% risk of complication. And at least our institution, more than a 99% success rate of actually implant with closure that meets IFU that allows them to come off their blood thinner. It's really, it's almost it's safer than a heart catheterization, which I think a lot of people don't realize. And so one of the couple of the spiel things I talk about is the ability to come off their blood thinner in 45 days, to not have the bruising that they have, to not have the bleeding episodes, but also, when people are making the choice of going back on the blood thinner after a major bleed, stroke is really the thing that drives people the most fear. Most of the people I talk to would rather die than have a stroke.
Yeah, totally.
And I think stroke is just one of those things that causes a lot of motion in patients. And so reassuring them then that this gives them stroke protection. And if they're having to make that choice over a life-threatening bleed versus not being in a blood thinner at all, this is a very happy medium and a very safe procedure to give them that choice. The other thing we do is a lot of patients obviously come in, they're not sure. This is the first time they've heard about it, or first time that they're really thinking about the Watchman procedure. We have a very good follow-up plan. So if a patient leaves that procedure not knowing what they want to do or wanting to think about it, or there's family members they want to discuss, or friends or church members they want to discuss with, we have our coordinator follow up with them within that next week to answer any questions, to really go over the procedure again. If they have more questions, call family members and really kind of make sure they're comfortable so that they're willing to proceed.
That's such a good point, Sam. I mean, there's a lot of patients I see in clinic where I always tell them, like, we can either schedule the procedure today, you can think about it and talk to your family, and we'll give you a lot of information to review the procedure. Or you can just say, hey, I don't really mind being on Eliquis, I can continue it. And so I try to give them multiple choice because patients always have issues with free response questions. So, but I'll say, like, I think 90% of the patients that say they want to think about it end up deciding to do it because we do that 1 week follow-up call with them to say, hey, just wanted to follow up. I didn't know if you had a chance to think about the procedure. So I think that's so important. Like, don't just stop the encounter once you see them in clinic. Make sure somebody follows up. And that's where I think having a dedicated LAAC coordinator is super powerful, because that's kind of all of what they do. And so that's the person that ends up calling them, is your LAAC coordinator.
Exactly. Our coordinator does all the teaching up front, and then they do the follow-up visit after the appointment over the phone. And I think the other, at least our markets, maybe like many markets out there, is we're in a centralized city, but our outreach is huge, 2-3 hours in all directions in very rural places. And so we've also tried to work, our coordinator is able to work with having more telehealth visits so patients don't have to travel down for that 6-month, 1-year, 2-year visits that's required, and allowing them to have TEs locally and training the local TE people on how to do Watchman and how to do Watchman post TEs so that patients don't have to travel. And by reassuring patients that they don't have to travel 3 hours for multiple visits has really, really helped, because a lot of these people are older and frail and have to depend on loved ones to drive them.
Yeah, no, that's a great point. I love that. So, so just kind of revisiting the mnemonic here. So you've scaled your program, you've kind of determine what type of sales pitch or spiel you're going to give patients so that you can articulate the procedure and the risks and benefits appropriately. And then the one thing that I found, and I know Sam's had the same experience, if you do one thing after watching this to increase your Watchman volume, get the outreach posters. And so these are posters that your Boston Scientific Therapy Awareness representative can give you. If you don't know who that is, you should find out and talk to your local clinical. But essentially all you have to do is call them and say, hey, I want you to put these posters, these therapy awareness posters. I'll show you an example of what the poster looks like here, in every single clinic that you can. And so I reached out to my partners and I said, hey, WATCHMAN is an underutilized device and therapy. I'd like patients to be aware that it exists and to have access to this therapy. And so I'm asking you to put this poster in your waiting room and in your clinic rooms that patients can view before they see you in clinic. And honestly, just putting these posters in my clinic and my partners' clinics and some of our outreach clinics, I think it's probably increased our WATCHMAN volume by 50 to 100 cases per year. Because the reality is that most referring physicians, in the 15 minutes they have to address the multitude of cardiac complaints these patients have, they don't have time to talk about WATCHMAN. And that's just the reality of healthcare that we live in right now. But if you have these posters up in your clinic and the patient's been primed to think about this procedure as an option for their AFib, you'd be amazed how many patients will actually ask their doctor, hey, can you tell me more about this WATCHMAN? Can I talk to someone about it? Can I get a referral to structural heart? And so these outreach posters are absolutely a game changer for outreach. And it's a super simple thing to do. And so, like I said, we've actually put them across from where the patient sits in clinic while they're waiting for the doctor to come in. And so they're sitting there, playing on their phone or looking at a book they brought. But ultimately, they're going to look at this poster and they're going to think about WATCHMAN. So, Sam, can you talk about your experience using these posters in your practice?
Mm-hmm. So we have very similar posters up in our structural heart office, so that every patient that comes in, we have our TAVR posters, our MitraClip posters, but many of those same patients, the same patients you're treating for mitral regurgitation or aortic stenosis, have AFib, and so they see these posters and they ask the questions. Even when I don't have the time to think about it, they ask the questions and sort of start the discussion. I think the other place we put it is we have an AFib clinic in our EP office. So we put a poster up similar to this in our AFib clinic. And EPs are great, but they're very busy. And so, spending the extra 15 minutes to talk about this is challenging for any physician, especially the EPs. And so they've loved it because the patients ask them about it. There's a number. We actually have our referring number on that poster for our structural heart office, so that the patients can then write it down. The EP or the primary cardiologist says, here's the number, write it down. We'll make the referral for you, or you're welcome to call. And it's a quick way to get the patient over to, so they can get more information about WATCHMAN.
Oh, I love that. Yeah. And I think, the framework through which you think about outreach for WATCHMAN is so different than TAVR or MitraClip, which most structural interventionalists are familiar with. If a patient's having symptoms from severe aortic stenosis or severe mitral regurgitation, they don't need consumer-facing materials to convince them they need to get treated. They feel that every day when they're doing their daily activities. WATCHMAN is such a more patient-facing kind of advertisement for this therapy, because the reality is, because it's so underutilized, you really do need to get in front of patients and make them aware of that. And regardless of what you think about direct-to-consumer advertising, which obviously has its concerns among our community, I think it's super valuable. And patients deserve to know about WATCHMAN, because, we see these patients languishing on their blood thinners. They're in with their third GI bleed, or they've been having hematuria and epistaxis, or they just have those, what I like to call Eliquis arms. Have you seen those, Sam, where you go to a clinic and you see your WATCHMAN patients and their arms are just covered in bruises? And so those are the patients that really should know about this therapy and ask their doctor. And to your point,
or even worse, the patients who aren't on it because people think they're too frail to be on a blood thinner. They've had a GI bleed, but now they're just off, or they're they have a couple of falls and somebody says too high risk for blood thinner. And instead they just leaving themselves at high risk for stroke.
Yeah, absolutely, man. Absolutely. So yeah, so step number 3, after you've scaled your program and after you've learned to kind of discuss this procedure with patients in an efficient manner, is get outreach posters, put them everywhere you can. Put them in the anticoagulation clinic where patients are sitting waiting to get their INR.
That's a great idea.
And they see that, oh my gosh, there's a different option for me. So the outreach posters are super simple. If you do one thing to increase your outreach for WATCHMAN, get the outreach posters in your clinic. So the fourth thing is, then we get into partner outreach. And so, the paradigm for outreach is that you start with inReach, right? So inReach is the collection of cardiologists and APPs in your initial health system and your network that are your partners and the APPs that you work with on a daily basis. And then you go to outreach. And so when I first came to Boise 4 years ago, I asked for a list of all of our referring physicians in our group. And I looked and I saw who are the top referring physicians. And those were usually our imagers who were working on the procedure with us, or our non-implanting, shared decision makers, because they see the benefit of this therapy every day. But then I looked at the people on the bottom of the list and I identified the partners that I had that were not referring for WATCHMAN, and the APPs that we had in our system that were not referring for WATCHMAN. And I sat down with them on a one-on-one basis. I went out to lunch with them, or we went to the cafeteria, the physician lounge, and I sat and I talked to them. I said, hey, I noticed you're not referring a lot of patients. I just wanted to have an opportunity to talk to you about the benefits of WATCHMAN and, this therapy. And, just recently I've talked to them about WATCHMAN Flex Pro, and I found that kind of more intimate one-on-one, or even a small group lunch or dinner has been super beneficial for identifying those healthcare providers that are not referring a lot, and getting them to understand the benefits of this therapy. So with that, Sam, can you talk a little bit about some of the benefits you've seen from your partner and physician outreach in your program?
So we took a very similar approach to you did. We looked to see who are the top referrings, and you want to shore those up, right? You want to talk. You don't want to skip over the people who are referring to you. You want to actually continue to give them feedback and to meet with them to show them the benefits that their patients are getting. And then there's a huge opportunity to find the people who are not. The first thing we did was do exactly you did. We'd sit down, we did dinners, we did lunch talks. We met with them. We did the outreach to all the referrings that send in patients within our own network, and met with them one-on-one in their office. I think a lunch goes a long way. People are busy. People don't necessarily have time for dinners all the time, but if you go to their office and do a lunch for their staff and or a lunch for them and their APPs, it goes a long way. And then the big thing we did actually is that we found a non-implanting physician, a cardiologist, who was really passionate about WATCHMAN due to some family connections with the WATCHMAN device, and a family member that suffered a stroke and a bleed. And having that person be a champion for our left atrial appendage occlusion program was great. If I go talk to somebody about WATCHMAN, it's a procedure that I do. What I don't want to come across as salesy, like I'm trying to sell them something. And so having someone who didn't necessarily have any skin in the game, that all they cared about was getting patients a therapy that maybe they wouldn't have gotten without sort of this outreach program, really goes a long way. And so this non-implanting physician will go out and give these talks, go out, meet primary care doctors, tell his own personal story, but then also explain the data and why it's a safe procedure, but why it has these benefits, and the fact that most patients aren't even getting the opportunity to have it really has gone a long way.
Yeah, no, I love that. And, I think to your point, the physicians that are referring a lot of patients, you still need to maintain that relationship. Mm-hmm. And I think one thing that's lost on a lot of structural heart operators is, at the end of the day, these referring physicians are entrusting their patients to us. And that's a really special thing, that they're trusting us with their patients' lives. And so, I always tell doctors, when you see a patient in clinic, that's the first touch point. And so you're obligated to text or call that referring physician and let them know the plan for their patient. I think a lot of doctors don't do that. They don't take the time to just get on their phone and text their referring physician and say, hey, I saw Mrs. Jones in clinic. She's a great WATCHMAN candidate. Thank you so much for referring her. And we've scheduled her for, May 31st, right? And then once you do the procedure, that's the second touch point. You text the physician and you say, hey, Mrs. Jones had her WATCHMAN. It went great. We put a 31 WATCHMAN Flex Pro in. We plan on doing a CT scan at 90 days to look for device position, and then et cetera, et cetera. And then even if you see them again in clinic after they've gotten off their blood thinner, that's another opportunity as a touch point for that physician. So really maintaining that relationship with your referring physicians and making sure they're aware of what's going on with their patients, because the last thing you want is for that patient to go back to their referring physician and let them know they got a WATCHMAN and the physician has no idea, right? Because that makes them look bad. That makes them look like they're not involved in their patient's care. And so I think that's something that's lost. So what is your kind of referring physician kind of communication look like, Sam?
That's exactly right. So that's the first thing I tell new fellows coming out. I know there are probably some fellows here on Murmur. And so a lot of places don't teach you how to be a good cardiologist to your referrings. Everyone teaches you the skills, the way to talk to patients, the way to treat patients, but no one actually tells you how to talk to referrings when you're in fellowship. And so my first call after I scrub out of any procedure is to call the referring. Even before I dictate or the procedure or put the post-procedure orders in, is I call the referring physician. And that touch point keeps them in the loop. And maybe a quick, hey, it happened, went great, exactly. 31 millimeter WATCHMAN Pro Flex went in, and Flex Pro went in, and everything went great. They're like, thank you, goodbye. But that means a lot to them, because when the family member calls them and says something about the WATCHMAN, they know. And that there's nothing more embarrassing for a referring physician to get a phone call or an office visit where they don't know something about their own patient.
Yeah.
So that is huge to keeping that relationship. So that's the first phone call I make every time.
So you call, you don't text.
I call, and even if they send me the voicemail, then I'll send a text. But I wanted them to hear my voice about how it went.
No, I love that. I love that. And the other thing I think that's really helpful, and this is not just for WATCHMAN, for other structural procedures, is especially if it's another interventional cardiologist or even a cardiologist, they like seeing pictures. And so, so I generally text, but I'll send them a picture of the deployment. And you can actually have your reps put that together for you if you want. You don't have to do it, but you can ask your rep, like, hey, can you send me pictures of the post-deployment WATCHMAN on all the cases today? I want to send it to my referrings. And I mean, you'd be amazed what that does just in terms of repeat business. Because the reality is it's much more efficient to have 10 referring physicians that are referring 20 to 30 WATCHMANs a year than 100 referring physicians that are referring 1 or 2, and so really protecting that relationship with your referrings and making sure they know you. And, I'll even talk to my referring physicians about, my hobbies, like let them know, like, who I am as a person. And, I always try to promote the program a little bit when I talk to them. I'll always try to promote, like, hey, last year we had 0% complications. We've got this new WATCHMAN Flex Pro. It should really help with any DRT issues. And so I think talking to that referring physician is an opportunity to promote your program a little bit. So
I agree. Keeping in touch, it's not, you don't want it just to be a business relationship, right? You want it to have a little bit of a personal relationship too. It goes a long way when they're thinking about who to refer to. They know you and not just your business. They're going to think of you.
Yeah, I love that. Great. So you scaled your program. You've learned how to talk to patients in clinic to articulate the benefits of the procedure. You've put your outreach posters up in clinic. You've kind of looked at your referring physician list and looked at your potential referring physician list and sat down with them or scheduled something. And by the way, the therapy awareness partners that I've had at Boston have been fantastic. They literally have a whole dedicated group that's job is to help you grow your volume. And so if you don't know them, or you haven't started talking to them about your strategy for outreach, now is the time. And it's a really good opportunity to meet with them, because ultimately, if you're starting in a new practice, or if you're new to a specific market like Nashville or Boise, and you don't really know the referring physician kind of geography, they know it. They live there. They've been there. They know the referring physicians. They know who is worth the time to go meet and who's not worth the time. So, so I think that's important, is reach out to your therapy awareness reps and work with them. And then
they're a very good extension too, because Boston will have your data, right? They have your complication rates, they have your success rates, and they can share those back about your program and be a cheerleader for your program, even when you're not. So I really want to emphasize that the outreach people are fantastic with Boston.
Yeah, and especially, I mean, you have a dedicated LAAC coordinator, which I love that idea. I kind of want to look into that. And is that the same as your AFib coordinator, Sam, or is that
completely different?
Totally different.
Totally different. Their only job is WATCHMAN. And there's actually good data we're an HCA group, and there's another HCA center in Florida that has pretty good data about really you almost need one full-time coordinator for almost every 75 to 100 procedures that you do, whether it's TAVR or MitraClip or WATCHMAN. And it's because it is so resource intensive, but those are the people that are going to help you grow.
Yeah, absolutely. And there's a huge problem right now with burnout among structural heart coordinators, because it's such a demanding job. I mean, it's such a rewarding job, but it's also so demanding. And I think being able to parse out those responsibilities and roles and have someone full time, especially if you're doing 300 a year, that more than warrants the FTE status for your administrators.
Exactly.
And so I think that's a great idea. I love it. And then, so last thing in terms of outreach strategies is extend your outreach to patients. And what I mean by this is most health systems have outreach coordinators. Most health systems have, marketing folks that work with your health system to advertise your programs. And so once you've reached out to your therapy awareness rep, once you've done the outreach posters and you've done the dinners or the one-on-ones, is look towards a strategy that involves marketing your program to patients. And so over the last 3 months, I've been working with our marketing coordinators at St. Alphonsus, which is our health system. And I've talked to them about the utility of using socials and having a landing page on our website where patients can go to learn more about the Watchman. And we actually have a dedicated patient assessment tool on that webpage where patients can calculate their CHA2DS2 VAS score to see if they're a candidate for Watchman. And then if they are a candidate for Watchman, that automatically directs them to a phone number to call to seek out a referral. And so it's not just reaching out to your partners, it's not just reaching out to your APPs, it's reaching out to patients and letting them aware that, hey, we have this great program in Boise where you can get a Watchman with a very low complication rate and a very high level of success. And if you are a candidate, reach out to us. And we've seen a huge benefit to that. We're getting about 100 referrals a month now, just for Watchman since we've implemented that kind of strategy. Wow. And then you can also do kind of paid advertising. So if a patient's in Nashville in Sam's Market and they want a Watchman and they Google, WATCHMAN programs, Nashville, you can actually do paid advertising to make your health system more relevant. You can do natural search in your website to make your website come up higher. And so that's kind of what I would say is outreach kind of 301, 401 is really extending the outreach of your program to patients and allowing patients to understand that you have a great program in your market and, hey, we've got great outcomes. Come visit us and talk about Watchman. So Sam, have you guys done anything?
Great idea. No, we have not. We've done it in the renal denervation field, some direct-to-patient advertising, but we have not done it in Watchman yet. And I'm going to steal your idea if that's okay.
No,
I think that's fantastic.
I can send you our landing page.
Overwhelming,
too.
But
yeah, and I'll put our landing page for my health system on the link for the video so people can see it. But it's been huge. And the other thing, Tom Wagner, who we've had on the program before. Mm-hmm. Probably the highest volume, who is the highest volume Watchman planner in the country. He does these patient symposia where his outreach folks and along with his therapy awareness folks at Boston Scientific will put on a weekend symposium for patients where they can go to his hospital and he'll give a talk on AFib and Watchman and stroke reduction strategies. And he's found that to be very successful. I've personally found that when I do that, I mostly get questions about like, hey, I've got a heart valve, or like, hey, I've got coronary disease. So you get a lot of non-Watchman related questions, but I still think it's beneficial. So Sam, have you done any of those kind of patient-facing symposia or anything like that?
We've done a couple. We haven't necessarily found them all that sort of fruitful yet, but I think I think we haven't figured out how to target that and how to advertise that those symposium. One of the things we've done, and like it's sort of direct to outpatient, is direct to patients, is really go to the primary care doctors. I think I was mentioning before is that at least in a lot of rural places, primary care doctors treat AFib. They don't necessarily refer all their patients to cardiologists. So I think getting in front of the patients really is also about getting in front of the primary care doctors.
Absolutely.
So it goes into patient outreach, it goes into outreach to patients, but we've done a lot of that rather than going straight to patients. It's been more straight to the primary care doctors and patients there, which has really helped us.
I love that. And have you guys, I think one of the other kind of last things to talk about with outreach is there's a number of Echo Alert, Epic-based slicer dicer type stuff, or even CardioCare, Ignite, two of the new third-party platforms to identify patients for your program. I've heard a lot of successful things about those. We haven't implemented that. We use that for our structural valve disease queries, but we haven't really used it for Watchman. Have you heard much about that, Sam, or have you guys utilized any of the third-party software to data mine patients who may be a candidate for Watchman?
Not for Watchman. We do the same. We have a program that we use for our structural valve clinic, and also for advanced heart failure has now used it to identify patients with heart failure. I can imagine how you could see, diagnosis code of AFib and anybody admitted with a GI bleed. You could use that to data mine sort of inpatient records. I think that would be an easy way to do it. Otherwise we have not, but AI, everyone knows is coming, and it's coming strong. And I think it's only going to help us capture patients that get lost.
Yeah, I love it, man. Cool. Well, awesome. Well, so we've gone through kind of the 5 key areas of outreach for Watchmen. Anything you think we haven't touched on, Sam, that's been important for your program and growth that we should talk about?
I know I can't emphasize enough that outreach and everything is great, and growing patients and growing volume is great. It's really working with your administrator about how to handle that. Watchman, as I said, is the fastest growing structural program in the world, and so our left atrial appendage occlusion is, and so really working with the administrators to show why it's important, why it's valuable, why the return on investment for both the physician but also the hospital is there, and really getting an infrastructure to support, because I think Watchmen could really carry forward a hospital financially. It's very beneficial, but it has to be done in large volume to do that.
Absolutely. No, I mean, I think when you look at the volume rebates you get for a high volume Watchman program, and you compound that with same day discharge, which
Mhm.
I'm sure you guys do as well, with a complication rate that's almost 0%, it's a very profitable program for the hospital. And I think there's
I
also a halo
agree.
effect where these patients have other medical problems that need therapy. And so absolutely. I think emphasizing that to your administrators, that of all the structural heart procedures, this is the one with a very good reimbursement, especially with a volume rebate, with a very low complication rate and same day discharge. I think
Mhm.
that's huge. Are you guys same day discharging all of your Watchman patients?
We are. It started with COVID. We weren't before COVID, and then COVID happened, and we were sort of forced to like everybody to figure out how to do more with less. And we started our program in which we had very strict criteria of who'd be same day discharge, but now we've extended to about 80% of people go home the same day.
Yeah. It's kind of crazy when you think about it now that we actually kept these patients overnight. It's like, all right, well, their groin's fine. You've pre-closed that. And with flex, the risk of pericardial fusion, especially late pericardial fusion, is so low. As long as
Exactly.
you're just doing a limited echo and that looks good, there's no reason to keep them in the hospital in my mind.
I
So
100% agree. I think Flex really changed that, and made it possible to do same day discharge.
yeah, I love it. Well, Sam, thank you so much, buddy. I really appreciate it. I think we got a lot of practical tips and tricks for folks looking to grow their Watchman volume. And this has been awesome. We look forward to having you more on Murmur. And yeah, man, good luck with everything.
Thanks, Joe, and thanks for having me on Murmur. Appreciate it.
Awesome.